there. All right. Well, let's get started. Welcome everybody to this Facebook Live. I have here Kyle Claussen with Resolve, which is one of our sponsors. We've been working with them for quite some time now. They do physician contract reviews. They do physician contract negotiations. They also do a lot of work with jobs as well. Helping you find a job as well as helping you negotiate the contract and everything for that. So, Kyle, welcome to the Facebook group. Welcome to this Facebook Live.
Thanks for having us.
So let's talk today about contracts. Let's talk about common contract terms to pay attention to. I know this is something you spend all day on, but many of the people who are listening to this or will listen to it later probably have not spent a great deal of time learning about contracts. So let's start at the very beginning. What are the contract terms to pay attention to?
Yeah, well, all of them, I guess, is the right answer. But there are some that have more effect than others. And the ones that I would make sure that you start out with would be anything that revolves around what your day in and day out life is supposed to look like with that employer. So I kind of call that the jobs category or bucket, meaning, do you have call? And if you have call, how much? Which location are you going to be providing service at if they've got 10 different sites? What days of the week are you working? Things like that. That should all fall underneath a duties and responsibilities type section in the agreement. And that's where I would start and pay attention to first. Flowing with that is if you're planning on doing any type of side gig, like starting a blog or anything else, you want to make sure your outside activities allow for that you're not going to be creating intellectual property that they're going to have a right to, make a claim on later, and that you actually have authority to go and do that. So paying attention to those two things first would be my starting recommendation. That's an area of the contract that we see a lot of people gloss over, and it tends to be one where they run into some dissatisfaction early on because they were promised one thing and it actually doesn't turn out to be true with those items. So start there. The second area is making sure you're being paid fairly. That's one of the biggest goals for us, is that you're in a contract that if you're busy at the median levels, that you're also earning the median. Right. And that if you're joining a group or an employer that's had a hard time recruiting, that you're getting the right incentives, whether that be a signing bonus or relocation allowance, retention bonuses, student loan forgiveness, all of those things, knowing your value and understanding what you're bringing to the organization. So that's kind of the second area. And the third area would be anything that would revolve around termination. So you plan on kind of worst case scenario, and especially as an attorney, that's my job, is to think of all the bad things that could happen, like COVID comes along and you may get furloughed or your pay all of a sudden gets cut. And so, we never thought that would happen. And then now this year it is happening. So can you get out of the contract? First of all, what are the procedures around that? If you can get out, then do you have any repayment obligations on those bonuses that you received? Who's paying for your malpractice insurance and tail coverage if you leave? Do you have a restrictive covenant or a non-compete, meaning where can you go to work next? All of those things fall into kind of that third category. But to really, really oversimplify it, if you can kind of hit those three buckets, I think you'll do better than most with your contract.
So the three big categories, I guess, are duties and responsibilities, compensation and payment, and how the relationship breaks up on both sides. It sounds
the marriage and the divorce. Yep, all at the same time.
So let's talk about leverage on each of those items. Can they be changed? Can they be negotiated? A lot of doctors go into a contract and they're told this is the standard contract. Where do doctors these days really have leverage?
I would say 99% of all employers use that exact line, is that this is the one that the last 10 doctors have signed, right? This is our standard template. We never change it. We have the advantage, or I have the advantage, of sitting on, the side of seeing what happens when we ask for these things to be done. And I would say 90% of the time, some change does happen, whether that's compensation, whether that's terms around the outside activities. So the answer is that it's still, supply and demand is still in your guys' favor. There's a shortage of physicians. They still need you just as much as you need them. But you have to be willing to ask. You have to know what your value is, right? And then have some leverage. And I think we're gonna talk about that here in a second. But if you're asking, can they be changed? The answer is yes, they can be.
And what about in COVID? Has that changed? Is the market tighter? Is it harder to get a job? Is it harder to negotiate now that there's all these docs whose pay have been cut or they've been furloughed? How's that changed this year?
I think it's delayed things. So there's still a shortage, right? I mean, healthcare didn't go away just because COVID, is a problem. So everybody that had a cataract before still has a cataract now, right? That needs to come out. And so what we're seeing is employers have kind of hit the pause button short term, but they are really now ramping up and hiring just like they would any other year. So for anybody coming out of training that's watching this, to think that in August or September of 2021, that COVID will still be shutting down our health system. And if you're signing a 2 or 3 year contract, project that into 2024, I think it's really unlikely, right? That this is going to continue on and continue to affect all these, elective cases and all these, non-essential type visits that they've tried to, really tighten up here, rightfully so. So has it affected hiring and contracts? It has. I think short term, you're seeing things like signing bonuses maybe be reduced and they're less likely to be offered right now than they had in the past. But from a fairness standpoint and from looking into the future standpoint, which is what all these contracts do, we're not seeing that have much effect on the terms being offered.
For those who are just joining us, I'm talking with Kyle Claussen of Resolve. They do physician contract review and negotiation. If you have questions for them at the end of this Facebook Live, we're going to take your questions and answer those specifically. So you can leave those in the comments below, and we'll answer those toward the end. But right now, we're talking about how to create leverage, how to take these terms that you're offered and see what you can do with them. And so let's talk about that. What can you do? For example, they want you to be on call every third night.
Right.
How do you go about changing that?
Yeah. So the biggest leverage point that anyone has in any negotiation is your ability to walk away from it and to go do something else, right? And not do something else like get a different career. But what I'm talking about is if you have 2 offers from employers within the same area, that gives you the power to bounce ideas back and forth between them. So if you have an offer that has call at 1 and 5 and another that has call at 1 and 3, that's really your best leverage point. And that would be true for anything, whether it's call or compensation or any of the restrictive covenant clauses. Having options is the most important thing.
So your BOTNA, your best alternative to a negotiated agreement, which is essentially another job offer.
Correct. Yeah. Here's a situation that happens more often than I would like it to for us, is that we will first interact with a client when they have interviewed at 3 or 4 places and they narrowed it down to 1. And that's when they decide that, okay, now that I've turned down offers 2, 3, and 4, I'm going to start to negotiate this one really hard. And the employer, may come back with the initial review and say, no, we're not going to do that. This is our standard contract. Well, if you've already turned down those other offers, like you just mentioned, you don't have a best alternative at that point. You've locked yourself into this thing. And we can talk about timing of when you should be going through this process. If you've locked yourself into a corner because you don't start looking for a job until 2 months before you need it, right? You're putting time pressure on yourself that's not required. So being able to vet the entire market, being able to see what's out there is extremely important.
Yeah, obviously the person with the most information and the most time and the most patience and the best alternative is going to win any negotiation, I suppose.
Correct. Yeah.
So any specific strategies you encourage people to have? I mean, it sounds like playing one employer off another is a pretty big part of it. Is it helpful if you sit down at the beginning and decide what's most important to you and focus on that in your negotiation, or what do you think is the best approach to begin with?
Yeah, I think so. I think there's some self-evaluation that needs to happen of what you're looking for. And so that if you're in training, again, this is different than if you're mid-career, but, deciding on things like, am I going to go into fellowship or not? Am I looking for a certain type of employer? Do I want to be in private practice, or do I really prefer a more hospital employed or a health system type approach? Am I open to living anywhere in the country, or do I have to live in Phoenix, right? Those are things that you should be deciding very early on, so you can actually go out and then vet that area and vet those practices to know who's hiring and who's not, because you all have been hounded by recruiters and these third parties, and you get text messages and emails and things like that. That's not the full picture of the market. That's a very limited sample. And even on the job boards, not every employer posts their jobs to a job board. A lot of these things are found via networking, your alumni connections, your colleagues. And so all of those things take time, and you are all very busy during your day. And so that to me is where most people fall short first. So that would be step one. And that's going to take you, 8 to 9 to 12 months, right, prior to actually moving. So starting that process early on is really key.
So start early, try to get multiple offers,
Mm-hmm.
and then once you have an offer, hone in on what you actually care about. Some people are going to care more about call and vacation, I suppose. Others will care more about salary and moving bonus and CME allowance and those sorts of things.
Mm-hmm.
What do you see contracts having these days? Do most employee contracts have a CME bonus? Do most of them pay a relocation bonus? Do most of them cover your health insurance and have a significant retirement match? I mean, what's kind of the general lay of the land these days for physician employee contracts?
Yeah, the general compensation model is still primarily some sort of base salary or base, guarantee, packaged with a production bonus that would also potentially have some type of quality component to it. We've been told for years that quality is going to be more and more important. We still see that only accounting for roughly 5% of the total comp package in most situations. And so those three things make up a majority of the compensation. There are going to be things like CME allowances, like you talked about, or reimbursements for boards that come into play. I would say 90% of the contracts that we see have relocation or moving allowances attached to them. That's very, very common. Signing bonuses historically have been in 70%, or more of the contracts that we've seen. This year has been a little bit different. Those have been reduced, like we talked about with COVID and some cash flow issues for the employers and the health systems out there. But you're still primarily looking at, if you're on a production, model, or if your specialty lends itself to that, a base with production with quality on top of that.
Do you find that employers are more flexible with things like a relocation allowance than just asking for a higher salary? Or do employers look at it all as one big pot of money and they don't care where it goes?
Both. So they look at it as one big pot of money. I think that's true. And they have budget and fair market value things to make sure they're in line with. But one-time payments, such as signing bonuses and relocation allowances, they're usually more willing to move on those things, because they often have kind of golden handcuffs attached to them as well, where you've got to stay for 2, 3, or 4 years to make sure that those are repaid. If they're increasing your base, that has effect on benefits of how much life insurance they're providing sometimes and other things. So the answer is they view it all as total compensation or a total number. And you need to get creative a little bit with moving between those buckets for your situation and what benefits you the most.
All right. Well, I think our first question coming in provides us a perfect segue into our next topic. Austin Haw wants to know, where's the best place to find the prevailing starting salaries in an area for a given specialty? Or basically, how do you determine your fair market value?
Yeah. Well, there's 2 ways to do that, in my opinion. There's certainly large surveys that are out there. MGMA, Sullivan and Cotter, AMGA, all of the large systems will utilize those, and most employers will utilize those to get an idea. Most of those surveys as well don't dial into a city. So if you try to sort the data and say, show me Denver, for example, you're going to get a bunch of zeros. It's not going to populate. You may get something at the Colorado level. You're more likely to get something in a regional or minor geography type region. So that's your starting point. That's what all of the contracts are going to reference. That's what they're going to use if they ever get audited. But to go back to our earlier conversation, the best fair market value is the offer that's also in the same city, right? So if you've got 2 offers in Denver, that's your best snapshot is what the prevailing salary is for that market at that time. So last year, the data is based on 12 months ago, just like any survey is. The rate today with COVID going on may be different than what even the surveys are showing you. So as many offers as you can get, I'm going to keep saying that. That's your best. Your best way to find it.
So MGMA data is kind of considered gold standard-ish.
Right.
But it seems like that's all controlled by the employers. There's no equivalent of, maybe Doximity where doctors put their salaries in. Maybe, I don't know, maybe that's an alternative. What do you think? Are the employers deliberately keeping the MGMA data low to aid themselves in negotiation?
It's certainly possible. It's heavily utilized by them, right? Meaning they're the ones submitting the information. I don't know that there's a lot of private practices, and especially maybe the more successful ones, that are going to report to that, right? They like to keep their information to themselves. Doximity does have a report. I have never seen an employer use that as a valid source of truth. The other concern I guess I would have with employers generally and MGMA generally long term is that they're very concerned about Stark, and I know that you know what that is, but you're not supposed to pay a physician more than what they're producing, right? And a lot of the contracts now will have caps on compensation, and they'll cap it at like the 75th percentile of MGMA or the 90th percentile of MGMA, where you can't ever go past that. It's this glass ceiling on your compensation. And so my concern is that as more and more physicians become employed, that if they all of a sudden have this cap at the 75th percentile, that then becomes the 100th percentile 5 years from now, and we're compressing compensation, and anybody that's taken statistics knows what that looks like over a period of time. So I think advocating and at least knowing what the medians are, even if it's their source of truth, a lot of them are paying below the median on their own survey. And so you really need to push for that.
Why do doctors take jobs that pay below median?
Because they don't have a better option.
Is that usually it? Do they just not know? Do they?
Well, they don't know.
Are they fixated on the area where they want to practice, or what causes them to do that? Because half of doctors are paid below average, right?
Well, that's what it would mean. Yeah, and half are paid more. I think it's because they don't vet their options. I mean, we're going to keep going back to this, but I think it's because they have to be in a certain town, right? It's hometown, or it's where their spouse wants to be, or whatever it is. And even if we go through, and this happens a lot, we'll identify 10 or 15 items in the contract that aren't necessarily benefiting them, right? But they are so locked into Minneapolis or San Diego or wherever they have to be that they're unwilling to go anywhere. Or they've been working there and they've got a kid that's in 8th grade, and they can't leave for 4 or 5 years until they're out of high school, right? And so there's a lot of other reasons, and sometimes they're good reasons. I mean, we don't want to tell people that it's all about the dollars, right? But it's certainly, most don't do themselves any favors by having alternatives. I'll put it that way.
Yeah. I've always been impressed that the intra-specialty pay difference is often much greater than the inter-specialty pay difference.
Yeah.
Has that been your experience as well?
It can be drastically different. Yes. And even within, the same specialty, like you're saying, within the same employer, we see enough of these to know that sometimes there's a conversion factor on a work RVU at 55, and for the other person working right next to them doing the exact same thing, it's 50. And so why is that? It's because one asked for it and the other one didn't. Right. And it's still a business at the end of the day. And if they can get by paying you less, they're going to.
For those just joining us, I'm talking with Kyle Claussen of Resolve.net. We're talking about physician negotiation and contract review. You can leave your questions in the comments below, and we'll get to as many of those as we can at the end of this live session. But let's turn now to those who are renegotiating a contract, those who are already working for this employer. What strategies would you suggest here for determining fair market value, maybe negotiating a better package than you initially started with, et cetera?
Yeah, the best part about, or maybe the worst part, I guess we'll get to this in a second. The best part about being in a position is you should have your own data. You should know exactly what you've done and the value that you're providing. And so that's different than a hypothetical, I'm new, I'm going to come in and I'm going to, be so busy and be really productive. If you can go back and show them that, you're producing at a rate, let's say the 65th percentile, and I'm only being paid at the 45th percentile, that's a strong argument, right? That's easy to show with numbers. Now, whether or not they'll actually get you there is a different discussion, but that is a very different strategy than somebody coming in and just comparing offers side by side. So that's step one. The other thing with anyone renegotiating is how locked in their current contract is for them. Do they have outs available or not? Because even if you say, hey, I'm being underpaid by whatever 25 percentiles in the survey, if the contract doesn't give you an out for 2 more years and there's a non-compete and there's nowhere for you to go, they're going to know that. And so that again reduces your leverage during those discussions. So being careful on the front end and using that kind of the preventative medicine, component to this to making sure you're planning your way out and planning your leverage points in the future is again something that we would really encourage you to pay attention to.
Let's turn a little bit to the breakup section of the contract. What happens when they want out? What happens when you want out? Can you give us some tips of what we ought to be paying attention to there in a contract?
Yeah. So most contracts are set up to auto renew, and that's a question that we get a lot. People think they signed a 2-year contract, and if the 2 years are up and been fulfilled, they can just walk away, kind of clean hands. Most contracts are structured to renew automatically for a year, after the term expires. And so what that means is you've got to have a procedure to actually end the relationship. Most of those relationships are going to end without cause, is what we call that, meaning nobody's in breach of contract. It's just that you want to go do something different or they want to go a different direction. So understanding what your notice period is under the without cause section is really important. And then taking a look at what your options are as far as where you can go underneath the non-compete based on the type of termination that happened. And then taking a look at the costs or financial obligations that you would have because of that type of termination as well. Meaning, do I have to pay for tail coverage? Do I have any repayment obligations on the relocation, the signing bonus, or whatever else you were given up front? So making sure you understand your term, making sure you're knowing what your notice obligations are, and then understanding kind of those factors that we just went through is where you would start.
What are you typically seeing in contracts these days as far as non-competes?
Almost all of them have it. So I think there's a general thought out there that non-competes are not enforceable or shouldn't be enforceable for physicians. Most states still allow them, and there's only a few that kind of have carved them out by statute, like California that says you can't have them for physicians. So most are going to run between 12 and 24 months as far as a time frame. Post termination, you can't work in a certain area for a year or two, and then the geographic area that they're restricting is often a mileage, but it can be counties that they would list out. It can be zip codes that they would list out, and how large that area is or how small is always determined based on population density and what they feel like their competitive draw area is. So in places like New York or other large metros, a couple miles would be what you'd expect. If you're in the middle of nowhere, Iowa, 50 to 100 miles, can happen. And that may be, reasonable for that area as well. So you're going to see them most likely. You need to be very careful on them as far as time, as far as geographic area, and then also where they're applying to, and if there's any type of exceptions that would come into play.
Now, I totally understand why somebody that was a gastroenterologist joining a practice would have a non-compete. But I don't know how much sense it makes for an emergency physician, a hospitalist, an anesthesiologist, a radiologist. Do those folks have much success getting rid of the non-competes? Because they seem like they're totally one-sided just to punish the doctor.
Yep, they usually are. And I think the argument is better in those situations, right? You're not, GI is a good example, dermatology, something that's more, where you can actually take your patients across the street and compete. Most of those will actually be structured just to the facilities that you're servicing. So if you're a hospitalist working for Sound or one of these larger employers, it may say that you can't go in and try to steal the contract from them and, be employed directly with the hospital. but it doesn't have the typical 10, 20, 30 mile radius attached to it. So there are differences based on specialty. I think the argument is in your favor in those specialties as well, whether or not they should apply at all. But again, if you can take them out up front in the contract, you don't have to worry about whether or not they're enforceable later on. And that's the whole goal of going through that process, is trying to remove any item that might be up for debate later.
And what are you seeing as far as malpractice goes? Are most people being offered an occurrence policy? Do most people have a claims made policy? And if so, what's going on with the tails in contracts these days?
Yeah, I wish everybody had an occurrence-based policy. There wouldn't be anything to touch on for that. But I would say probably 20% or so have an occurrence-based policy that we see. The rest have claims made, which require tail. And then within the tail categories of who's paying for that and who's responsible for the cost on that, you really get 4 typical outcomes. It's either that the employer pays for all of it, or the other end of the spectrum is that the physician is responsible for all of it. And then the 2 ways that we see folks meet in the middle on that is either a credit type system or a vesting schedule over time, where for every year that you're there, a certain percentage is paid or allocated towards your tail costs. So if you've been there for 3 years, for example, they'd pay for all of it. If you're there for 2 years, they'd pay for 2/3 of it, that type of thing. Or the other way to meet in the middle is to purely base it on who walks away and who ends the relationship. So if the physician walks away, they pay for it. But if the employer lets them go, the employer pays for it. So it's kind of this wait and see who walks away first type of strategy.
Yeah, that was the way mine was actually written 10 years ago when I joined my current group. And luckily, a couple of years later, we just went to an occurrence policy. So all of my younger partners have never had to deal with that issue. But I actually priced it out. My tail was $55,000. It was $55,000 to walk away. It was a big deal. So
tail is often the equivalent of roughly a signing bonus. So when people are seeing those numbers, they want to pay attention to the signing bonus, but tail can be just as expensive or more.
Yeah, for sure. What about some of these bonus amounts? I mean, they give you a relocation bonus. You typically have to pay it back if you leave early, or CME allowance, or these other sorts of things. What kind of restrictions do you see there in the contracts?
The relocation allowance and the signing bonus and or residency fellowship stipends, any money that they've fronted to you early usually has some type of repayment schedule on it. Other things like CME allowances or licensing and dues, that's less common, where you'd have to pay that back. So what I would look at is the amount that you're receiving and then the time period attached to that. So obviously the bigger the number is, the longer they're going to expect you to stay. Relocation is often forgiven in 12 months. So during that first year, as long as you stay for a year, that amount is taken care of. And that's usually because the relocation is between $5,000 and $15,000. So it's not a large percentage of your compensation. On the signing bonus or student loan forgiveness or whatever that is, usually between $20,000 and $30,000 a year is what we'll see forgiven on an annual basis. And so if it's, if it's $100,000, you're looking at probably a 5-year repayment. If it's $20,000, maybe 1 year. But again, that's going to vary by employer. There's no general rule for that.
Are you seeing a lot of contracts that have student loan repayment provision sorts of things, and why, if so?
We are not seeing a lot of that. So I think it's obviously a need. I mean, I think there's more physicians now with student loan debt than there ever has been, but no, we're not seeing many employers tap into that benefit. I think it's a total number for them. So when they're looking at what they're paying underneath MGMA or any other survey, they're trying to keep the total dollars as low as they can, and all of those numbers would flow through to that total compensation number that they're trying to stay under. So if you have a signing bonus, if you have a retention payment, all those things are going to show up as taxable income to you, which then means it counts towards your total comp under their analysis.
So do you think if you wanted to have them pay directly to your student loans, you probably could, because they're just looking at it that way, but there's really no point?
Potentially. I mean, and underneath, some of the more recent legislation, they can get some of that tax-free, right? But the amounts that we're talking about for physicians, I mean, most of that is going to be considered taxable income.
Yeah. All right. So for those who are just joining us, I've been talking with Kyle Claussen of Resolve.net about physician contract review and negotiation. We're going to be wrapping up here soon. So if you want to ask Kyle your question, now is a great chance. Free questions to somebody who looks at contracts all day long. Just put them in under the stream you see there in the comments, and we'll answer them. Any other topics that you think people ought to know, Kyle, when they're looking into their job search? And I mean, I think most people seem to start with location. Do you think that's a smart way to start or a bad way to start, or what's
Yeah,
the best way to deal with that?
I think that's true. I think, people look at either location as a lever or at total comp, right? Just they're going to go wherever they can make the most money, or they're looking at a certain type of practice that they want to be in. And between those three things, they're going to end up prioritizing one of those more heavily to find the position that they want. I would say that if you actually do your homework the right way, I think if you pick a location that's large enough, I mean, it can't be 2 blocks in New York City type of thing, but if you have, a 20 or 30 mile radius, and you're doing your homework the right way, I think you can find multiple options and you can find multiple practice types and styles to actually compare and to vet side by side. There's a real lack of transparency right now in just the physician recruitment market, and there always has been. But I think, going through that process and utilizing all the tools that are available to you to vet that and to not lean on and not rely on physician recruitment is really step one. And if you can handle that compartment, I think picking it based on geography is completely fine. There's probably more options than you're even aware of if you do all the right steps.
Yeah, I'm always surprised when somebody emails me and says, I don't really care where I live. And I'm like, really? That seems so odd to me. You really don't care?
Yeah.
But if someone's like that and they just want to go where the money is, where's the money?
Well, if you're looking for guaranteed money, the most money is going to tend to be in more rural areas or places that have had long vacancies they can't hire, and so they're going to offer you a lot of incentive to come there. If you're looking for volume and you don't care about year one guarantees, then I think you're looking at very practice specific details, right? You can make a lot of money in really any geography as long as you get the volume to get through. If you're in a specialty like hospitalist where it's just shift work and volume's not an issue for you, well then I think looking in a more rural location, the smaller towns is where the highest dollars are going to end up.
Small town Midwest or just small town anywhere?
Small town anywhere, but Midwest and South tend to pay more. But the Midwest, by and large, if you are willing to move to North and South Dakota, Minnesota, Wisconsin, that type of area, that tends to be where the compensation is highest under the surveys anyway.
So maybe those of you with massive student loans, that's what you ought to key in on.
Right.
Well, I'm not seeing a lot of other questions popping up here. Sometimes right at the very end, we get a whole bunch of them, but maybe it's because we covered the subject so comprehensively as we went along. But I sure appreciate you coming on here. If people want to enlist you for your help, what is the best way for them to get a hold of you?
Yeah, so they can go to resolve.net and send us a message that way. My email is kyle@resolve.net if they want to get in touch with us there as well. I'm happy to try to answer questions if this is on Facebook later on with questions that come in. But we're always looking for ways to help and empower physicians. And so any questions that come in, we'll try to answer. Okay.
Appreciate your time and coming on for this Facebook Live here. Thank you.
Thanks.